Hello, my name is Eddie Haupt. I'll be talking about computer assistance or enabling technology in total ankle arthroplasty. We're going to specifically focus on patient-specific instruments and GPS. I'm calling into you live from Florida, and so thank you for watching this talk. I think disclosures before we start, I think I have some relevant ones. I was the first surgeon to do this computer-navigated ankle replacement in the world. I probably still have the most cases done. I have multiple studies in process, some that you'll see in this talk. I don't get any royalties, but I definitely want this technology to work and believe in it. And I have some ones that are not relevant too. So what about me? I am from the Atlantic coast of Central Florida, a little town called Merritt Island. Everyone there works in the space industry next to Kennedy Space Center, which is currently famous for the amount of Tesla rockets being launched. So, that's the industry that we're in there. I went on a football scholarship to the University of Florida, which is a state university there. It's very academically good. And, chased a dream there to play professional football. I challenge you to see who I am in this picture. I went there to medical school. We're our mascot of the alligators. And so there's our Florida Gator doctor as well. And I was an orthopedic surgery resident also there. Here's my classmates that are doing spine and adult recon. It was a wonderful place to train. I met my wife with 3 beautiful daughters, all while in Gainesville, Florida as well. We ultimately went to California. Here's us in Hollywood when we first got there, when the girls were pretty young, to train with these 4 amazing mentors in fellowship, 2 of which, Dave Thorderson and Glenn Pfeffer, have been presidents of the AOFAS, and I think at least one more person's probably going to be in the leadership line there too. So wonderful place for fellowship. Ultimately, I came back home. So that bottom heart is Merritt Island, and the top heart with the little blue check is in Jacksonville, where I currently am. There's a Mayo Clinic in Jacksonville, Florida, and that's where I practice. Returned home. We have a beautiful hospital here, and obviously a busy total ankle practice. Those girls are a little bigger now, doing more things. We're not just taking pictures next to the Hollywood sign, but I'm very grateful to be here giving you this talk today. So, let's get started. What is computer-assisted surgery? Specific to total ankles, we only care about 3 and 4, which are navigation and patient-specific instruments. Both of these are enabling technologies that help make the surgery easier for the surgeon. What are the advantages? Well, there's increased precision and accuracy of the surgery. This is in every joint that has been studied: the shoulder, the hip, the knee, the ankle. There's reduced variability of placement of the implants because of this. And I think the most important takeaway is that it equalizes training level. The surgeon that does 10 of these a year will perform as well as the surgeon that does 150. So enabling technology definitely has benefits. Very interestingly, does it ever lead to better patient outcomes on patient-reported outcome scores? The answer is actually no. But interestingly, I think these studies have bias. The main thing about these studies is that they are performed at very high volume centers. And so the study, to be able to look at 150 total ankles performed with standard guides versus 150 with patient-specific guides, you have to be a pretty busy center. And so, are these studies even looking at who we really care about, which are the surgeons that really benefit from the enabling technology? I would argue no. Similarly, we're going to look at comparisons of the accuracy, specifically for the first version of this, which was the prophecy system that came out in 2014. There's been a bunch of studies on accuracy on this, all with radiographs. Do they show that it's been better than conventional? Well, it also depends on the threshold that you set for accuracy. So most studies will set a threshold of 5 degrees, plus or minus 5. So from 85 to 95, for example, for the coronal plane. Sometimes less than 3 and sometimes less than 2. Is that better than a surgeon using conventional instruments? Well, the biggest study that I could find with the Infinity came to us from HSS, and the answer was no. They weren't more accurate than standard guides. But again, these are very busy surgeons that are routinely doing these surgeries, and so perhaps there is some selection bias there. I think something really interesting to look at, these are tables from the study. They're setting the threshold at different points, 3 degrees, 3 to 5 degrees, greater than 5. Notice that, it's pretty easy to get the implants within a 5-degree threshold. Here, they were only outside of that 4 and 1% of the time, meaning that the system was accurate 96% of the time or 99% of the time with PSI. It's really hard to beat the 3-degree threshold. And so, there's something where 10% of the implants are falling outside of that 3 degrees. Pretty interesting. If we look at the in-bone, that's probably the second most popular implant. Same thing. Almost all of them are within 5 degrees. Only 70% are within 2 degrees. That's pretty interesting. That's just very hard to hit that perfectly neutral target. When we look at a comparison of standard guides, otherwise known as Big Bertha, to the PSI guides, there was no difference found. Again, I really want to highlight that these are two very busy surgeons. This is 40 versus 40 in a like a 3 or 4 year span. So there's some inherent selection bias to this. This is actually two different surgeons, one performing all PSI and one performing all extramedullary guides. But the accuracy there is a pretty tight range. No difference noted. They're clearly setting up Big Bertha as kind of a challenge and intimidating to some surgeons. But it's a great system. It's what my preferred way of doing these is. But again, I really want to highlight, this is an excerpt from that paper. The surgeons achieved alignment within 2 degrees. So again, that very narrow target. And only 65% on the mortise and 59% on the sagittal view. So something stops us from being able to get within 2 or 3 degrees. What are the take-homes from all this data? PSI does not seem to be more accurate than conventional instruments. However, there's some clear study biases there. And it's very hard to beat the error of plus or minus 2, regardless of the surgeon, the implant, or the system. So I would argue, is this even the guides? Or is it really what is the common theme of all these? Well, there's an interpretation of fluoroscopy step. Is it that? Or is it something having to do with impacting the implants? I would argue it's probably fluoro. What about rotation? Well, axial rotation is a very interesting thing. It's very hard to discern on two-dimensional images. You need CAT scans for this. There haven't been a whole lot of pre versus post-op CT scan studies. Here's one that I did looking at a consecutive series of my own PSI implants pre versus post-op. Could we match the template? And I was very much interested in rotation. So I think this really begs the question. I think I was within plus or minus 2 there quite a bit, except on axial rotation. And I have a huge range here. Look at this. 7 degrees of internal rotation to 12 degrees of external rotation. That's relative to the template. So there's an 18-degree range swing from what we planned. We planned all these from the gutter bisector. And I think, to me, you have to ask the question here, who's wrong? The template or the surgeon? And so I don't, clearly I'm the surgeon in that study, so I find it easy to blame myself. But I think this really brings up a good question, that if we're planning all these for the gutter bisector, what is that even based on? Is that anatomic? Is that where the rotation implant needs to be all the time? This system, the Advita Legacy tray, did not require you to set rotation as you were doing the case. And so you can make your cuts. You just set rotation on the tibia. But you didn't necessarily have to set rotation to make the cuts and choose where the implant's going to go. And so after the bone resections were removed, I could put the rotation where I thought was ideal for the patient anatomy. And I would say that was clearly different than what the planned gutter bisector would have given me a lot of times. So more coming on that as we go. What are other benefits of PSI? Well, you use less fluoro. There's 30 minutes less of operative time, again, in very busy surgery groups, 190 versus 167 mean OR minutes. That's meaningful time there as the tourniquet's running out. Surgeons enjoy templating. I definitely enjoy the templating process too. The disadvantages of PSI are you have to rely on those 3D printed blocks. But you set the resection. You have less flexibility during the case if somehow the ankle is more lax than you expected. There's a nominal extra cost to this, but it's not zero. And you can't use it with anterior plates or other implants, which may cause interference. An ankle like this is what really made me want to move away from PSI. I see a lot of these in my practice. The little valgus tilted arthritis. This isn't a flat foot. This is most likely paradoxical chronic lateral ligament instability causing the valgus, that they've worn more on the lateral side due to chronic ATFL laxity. A patient like this, I'm expecting to be lax. And so PSI to me, and having to set the resections before I walk into the case, it takes away my ability to call an audible and do an under resection there and make soft tissue balancing more simple for me. So I really didn't like that idea with PSI. So what else is there? Well, there's navigation. I think a lot of people see this as news to them, but there is navigation in total ankle replacement. What is navigation? Well, it's just that you use the conventional instruments, but a computer guides you to get there. So you make a template, you set what that is, and then the computer will recognize where the template is supposed to be. And then the guidance will help you place the instruments in the place of the template. Obviously, you can change the template as you go during the case, which is unique to navigation over PSI. How is it done? Well, you get a CT scan just like you do for PSI. Those are used to make a three-dimensional model of the bones. During the case, you're going to set up an optical tracker system that uses line of sight. So there's a camera that looks at a tracker attached to the tibia and a tracker attached to the talus. You then use a probe to show the tracker that the three-dimensional shapes that you're seeing in the OR match the three-dimensional model that was created from the CT scan. Once you do, the system also gives you a reference point to know how close you are to the model it's expecting, with all green obviously being good. But that's exactly how you teach it, what you're seeing, and then it helps guide you to the position of your template. Is the navigation accurate? Well, in a laboratory setting, greater than 99% of these are within 1 degree of error. So this is a study that was recently accepted by the Academy of American Orthopedic Surgeons research journal. We took 12 sawbone specimens and performed the navigation total ankle replacement, looking at the accuracy of the cuts. And you'll see these are all I don't have the signs on there because it switches, but they're all less than 1 degree or 1 millimeter in every plane. So it's very accurate in a laboratory setting. I think the obvious question is, well, what about PSI? How does PSI do in the exact same setting? Well, we did that too. 12 more sawbones with PSI guides attached, and the PSI was also very accurate. The only thing that fell outside of this was tibial closed slope. And I think that's a very precise error that I made, right? This is me performing this surgery, and I had 3 degrees of dorsiflexed or open slope on the tibia. Very reproducibly. I was plus or minus 1 with this 3-degree slope, and I would say, as an experienced PSI user, some of that might be just my eye is trained that way, right? It's my interpretation of fluoro again, might be the issue. I just want to point out too that sagittal plane errors are the most common in total ankle arthroplasty. That's been found in many different studies, and so this fits that trend as well. Something about the sagittal plane is harder to reproduce. Is there data in vivo? Well, some of these have been accepted for podiums at the Foot Society this year, so please come to that meeting and you'll see us present these there. But here's my in vivo data. I talked about I was the first one to do this, and we have the biggest series. And so, how does it compare to that PSI study that I published? Well, these are pre-op. What my settings were, essentially what my template was. I wanted a neutral varus valgus, neutral slope, tibial rotation. I set it at about a mean of negative 0.5 degrees of what we consider to be the bimalleolar axis. The cut height was generally set somewhere around 9. Talus was varus valgus neutral, and the cut height was generally somewhere around 6. And how close did I get to those? Well, the varus valgus was within plus or minus 2, which is fantastic. That's the most accurate we've seen there. The tibial cut height, again, the cut heights were very accurate. Varus valgus extremely accurate. Very interestingly, the slope of this implant again is a couple degrees dorsiflexed with a very tight, low variability. And so some of that, like I said, is it me? Is it the way the implant's impacted? I don't know, but there seems to always be a little bit of dorsiflexion of the tibial slope. If we try to compare that small sample that I have measured so far, which is 8 navigation patients to PSI, well, there really isn't statistical significance, but there's a lot of trends, right? Everything seems a little bit more accurate in the GPS system, and I don't know if this is because the sample size is too small, or if this is because they clearly aren't statistically different, but we'll see. I would say the cut heights definitely and varus valgus seem to be more accurate. So what do we know about navigation? Well, it matches upon or slightly improves upon PSI's accuracy. We'll see what happens as I get to an equal number. It does allow intraoperative flexibility, which I really like. You can adjust for soft tissue laxity. You can get post-cut information with a cut checker. Other benefits might be it also should reduce fluoroscopy usage. It hasn't been borne out in the literature yet. It probably would allow surgeons to go back to using a mini C-arm with total ankles, which Sounds cumbersome, but it also removes that x-ray tech from the room, which has value. There's definitely better rotational information with the navigation than there is compared to PSI and conventional, because there's something else making measurements other than your eyeball on a two-dimensional image. What are the downsides? Well, you have to place tracker pins. That takes time. I'm experienced, and it takes me 7 to 10 minutes, I would say, on average, if everything goes perfect. So there's some time added in that you obviously get back having to take less fluoroscopy. You have to fix the trackers to the bones. You have to keep them protected. They must stay rigidly fixed with no jostling until you're finished with the GPS. And you're obviously still reliant on obtaining a perioperative CT with the appropriate protocol to be able to set this up. So what's the summary? I would say both navigation and PSI, these are both enabling technology. They both have benefits. They improve your accuracy. They decrease OR time. Those are all good things. The advantages and disadvantages, I think, really need to be matched on the surgeon's personality and the case at hand. If you like fiddle factor, I love fiddle factor, and you expect laxity or you really want to be able to tinker with things during the case, you need to do navigation. If you're somebody who just wants it to be the most straightforward slam dunk case, it's something you're going for maximum speed. There isn't a lot of expectations of deviations. Do PSI. That is definitely more straightforward and faster. If you're a newer surgeon, you probably also would rather do PSI because there's less steps. Is the difference large enough here for any of these technologies for experienced surgeons for it to matter? Time will tell. Let's just show you how to do a GPS walkthrough. I think that's something important here. So here's that same case that made me nervous about PSI. We're going to do a total ankle on this. They'll need to get a CT scan pre-op with obviously the specific protocol to allow us to establish the 3D model. That takes about 2 weeks to process. Extra equipment's going to need to come with me for the case. There's one extra tray that has the trackers. There's some disposables with pins and so forth to attach these to the bone. The GPS station is free. Your hospital does not have to buy it. That's offered worldwide to try to promote the use of the product. You will template and plan the case on the tablet that comes with the station. Soon this will be on the web, but you'll set your rotation, varus, valgus, and slope to exactly where you want them during the case. You can also see sizing information about the different sizes. So you can go through all that both on CT scans and on three-dimensional models. The setup, we're going to use a large C-arm. The GPS station is going to be on the contralateral side from the patient's knee, on the same side that the C-arm would come from. So I'm standing at the foot of the bed, and here's an ankle with this exposed. The C-arm will come in. We're going to have the GPS station as close as we can get, but just enough room for the C-arm to pass for lateral images. This is a camera system that works via line of sight and triangulation. So these trackers need to be able to be seen by the camera unit the whole time. So the closer, the better. You can see that I'm a tall surgeon, and so eye level for me is almost certainly too high. Sometimes I'll get error messages as I'm doing this, but it's because the station is too far away from the patient. And so we've learned to kind of get this low and as close as we can to the leg. So I'll make my typical exposure, like I put the tourniquet up, I start the case, I make the exposure. When I'm ready to start putting the guides on is when I place the tracker pins in. I'm coming up here to place the tibial trackers, which are placed about 10 centimeters above the ankle joint. I'm going to come through the skin percutaneously in the leg to fix these bicortically in the tibia. I generally do an angle like this that aims a little bit posterior. I raise my hand up to aim posterior. The reason for that is that I can rotate the leg in internal and external rotation without these pins striking against the bed. For the talus, I think this is the easiest way to do it. Through the exposure, I will poke the pins percutaneously and look at them inside the joint. That way I can see the pin tip. I think this is a tricky shot on fluoro, so I try to make this as easy as possible. So I poke it through the medial skin. I look at it as it starts on the talus. Then I'll advance the same thing, the pins aiming a little bit posterior. There's a parallel pin guide for both of these to help you aim the second pin. But I generally I do that so I know that I'm in the talus and I can take less fluoro shots. In the beginning, I almost never take fluoro shots at where the pins are now because I have a lot of confidence in this. But in the beginning, I would take fluoro shots and make sure that both my pins are in the talus, and I like the bone stock that those are in. I think that's a good idea. The trackers, I'll assemble them with this little piece called a bone fixator that attaches to those pins. There's a little orange light that you can see above the letter T. T is for tibia. The orange light will turn green when the camera sees it, and the tracker is seen by the camera. So I'll arrange those, slide them down these parallel pins, attach them using a screwdriver, while making sure that the camera can see it. After those have been attached for the tibia and the talus, I'll begin registration using this probe. The probe, like I said, is going to it's going to show the camera that the three-dimensional leg or tibia, talus that you're seeing match what it expects from the CT scan. So I'm showing this just to highlight the position of the hands while this is going on. You have to leave this little white tracker next to my index finger of my right hand there open. Frequently, new users will cover that up accidentally. There's a button underneath my index finger. I'm holding it with two hands. What really matters here is that the tip is as close to the surface or structure being referenced as it could possibly be. And so you want this to be in contact the entire time that you're hitting the button. So in this one, I'm taking a tibial tubercle shot. I'm showing you with the pin where the tubercle, I think, is. And so I'm holding this as stable as can be while taking the registrations. There's shapes, and the system will walk you through what all to look at. The hardest ones to get are the intra-articular references. So in the top right, you can see it's showing you the articular surface of the lateral distal tibia. To do that, you do have to open the joint up, and I generally use a 1/4-inch osteotome to do that. In one hand, and my left hand here, and my right hand's using the probe. Here's a picture of what I'm doing. So my left hand pries the joint open using an osteotome. Again, you're not trying to disturb any of the bony landmarks, but just getting enough space that you can paint the surface of the joint with the probe. Here's my results of that. I'm pretty good. There's a couple spots that were yellow, meaning greater than 0.2 millimeters away from what it expected, and we double checked those, but ultimately accepted it. Here I am double checking those. I can place the probe on the screen and see how far away that is, and so I still like this. We advanced. We'll repeat that process on the talus. And then here's why you did this whole thing, is that you can navigate your guides into position. So this is the standard resection guide for the Advita Vantage ankle system. I would say that I'm pointing out here what is a wrong position. You want to make sure these fine adjustment knobs are closer to 0 so that you can make tiny adjustments more easily. I'm going to place, you can notice that there's a tracker on the talus at the bottom of the image. There's the tibial tracker there, and then there's a third tracker in the cut slot, and that's how this thing works. And here's how we do it. So I have that G tracker in the slot, or excuse me, first I'm checking a range of motion check here, so you do get soft tissue laxity data that the system is tracking. You can see the talus moving around on the screen. Here in this middle image, after the range of motion acquisition, my cut guide is getting placed onto the leg. I think this is a longer video because we're going to get this close, and then the G tracker's in the slot, and I'm not taking any fluoro right now. I'm going to look up at the screen, and my rep is taking the video here. You can see this white line is where the cut guide is. So I'm going to move that until we match the location of my template, and then it will turn green. This is subtle, and you can see the color change there. It's turning green. So I have the cut height correct, varus valgus is correct. And generally, the last thing that I'm doing is setting rotation. So I do these just like you were supposed to from the technique guide. That I place the guide, I get the resection height close, and then I will move from proximal to distal, setting tibial slope, varus valgus, and then the last piece of this is that medial lateral translation and rotation. So here's the first fluoro shot I've taken of the cut guide, right? And I would say it's exactly where I've templated it. I'm very happy with it. Notice on the image here on the right, we can see the slope. These two bars in the Advita system, one is at 11 and one is at 7. And so I set this at a 9 millimeter cut height, and it's spot on. We're going to do the same process again with the talus after you remove the tibial resection blocks. I think it's pretty straightforward how that occurs, right? And you can see in this last image that or you could see that the cut height was green. Here's a nice fluoro shot again showing the location of the talus cut. I'm looking at the slope. I'm looking at AP varus valgus here on the right image. And I'm pretty happy with that. So there's my final fluoro images on the left, and ultimately the patient's X-rays on the right. And I'm really happy with that X-ray, right? So the accuracy of this system is fantastic, and I think that's the main takeaway here is that it definitely is helping me, who's otherwise a busy surgeon, perform even better. So thank you for your time. That's all I have to say about navigation and patient-specific instruments. I'm happy to be here and grateful to be invited for this talk. Please send me any questions electronically. Thank you.
Estamos en el último tema, que es un tema también apasionante, que son, abrimos la puerta de las prótesis de tobillo y la innovación y las últimas tendencias en prótesis de tobillo. Y bueno, hemos pasado, como estábamos hablando antes, de una artrodesis que era el estándar hace unas décadas a unas prótesis que han ido evolucionando, primera, segunda, tercera generación, y ahora las prótesis ya están bastante estandarizadas. ¿Y ahora qué nos queda? ¿Ahora qué nos queda?
Claro. De hecho, haciendo un poco de memoria, no sé bueno, yo cuando empecé la residencia no se ponían prótesis de tobillo, había 2 o 3 cirujanos por aquí y por allí que ponían, lo veíamos allí de lejos como casi bichos raros, atrevidos, ¿no? Claro, yo la primera prótesis la vi a los 5 o 6 años de haber acabado la
Sí.
residencia, ¿no?
Y ahora los residentes quieren poner prótesis casi.
Ahora los residentes quieren poner prótesis. Yo creo que también pasamos de temerle mucho, ¿no? Por la indicación, por las complicaciones, el cambio de generación, yo creo que, ¿no? El bajar el stock óseo al mínimo, la mínima resección, cada vez hay menos complicaciones. Yo creo que eso nos da un poco de seguridad de trabajar bien, ¿no?
Claro, ¿no? La evolución ha sido buena, los resultados buenos, los resultados también, una de las cosas que también, esto lo leí bien en la rodilla, al saber que tienes una revisión en caso de que te fallara fácil, hace que tu indicación sea más fácil de decir, bueno, pues ponemos una prótesis y de aquí 6 años, 7 años, lo que sea, falla, pues revisamos y ya está. Y mientras tanto el paciente ha estado bien. Y este ha sido el caso, ¿no?
Sí.
Que nuestra experiencia ha sido esto. Hemos empezado haciendo mucha artrodesis, abrimos la puerta de prótesis, hicimos incluso cursos de prótesis y bien, y ahora estamos que queremos un poquito más, queremos mejorar. ¿Y cómo se puede mejorar? Pues claro, poniendo la prótesis bien en ese paciente estándar.
Claro, al final yo creo que hemos aprendido a poner una prótesis de una manera segura y ahora nos queda un poco ¿no? la alteración milimétrica, ¿no? Porque al final vemos una radiografía bien, ¿no? Hemos hecho la prótesis, la radiografía se ve bien, nosotros estamos contentos, pero con el tiempo el paciente no está tan contento, se gasta más de un lado. Yo creo que aquí es donde tiene la cabida, ¿no? La PSI,
La PSI.
la navegación también, ¿no?
Sí, la posición, entender bien que primero en qué tobillo ponemos esta prótesis, el TAC encarga o no encarga, o el TAC preoperatorio quizás tendría que ser más estandarizado para visualizar bien dónde vamos a poner esta prótesis, y la prótesis en guías personalizadas o incluso navegadas, que esto es un poco lo que está la industria de la prótesis, ya sea en rodilla, en cadera, en hombro, sí, guiándose o yendo para aquí. No tenemos experiencia en esto, o una experiencia
Todavía
limitada aún.
Bueno, ahora una ¿no? de la historia de la navegación precisamente, hay articulaciones donde ha intentado penetrar y ser un gol estándar y no ha llegado a hacerlo. Luego hay otras donde parece que sí tiene un auge, ¿no? Por ejemplo, tanto la navegación y la robotización de la rodilla, ¿no? Parece ser, no sé si un gol estándar, pero empieza a estar bastante establecido. El tobillo puede que acabe siéndolo, ¿no?
Sí, sí, sí. No sé si llegará al robot en el tobillo o no, pero bueno, es una opción. Quizás la N más baja o muchísimo más baja que en la rodilla nos limita, pero bueno, yo creo que
Bueno,
hay recorrido para hacer esto y para mejorar.
Yo creo que ahora también un poco el avance tecnológico se ha acelerado con el manejo de datos de una manera tan rápida que lo que antes era una tecnología muy lenta, ahora también está ganando fuelle. O sea, el hecho de que ahora con un TAC muy bueno nos puedan mirar todos los ángulos in situ y en el momento, yo creo que nos dará resultados clínicos un poco más rápido de lo que sabíamos. No dejando de lado la curva de aprendizaje, ¿no? No, poner una prótesis es desde la indicación hasta la revisión.
Sí, sí, sí. Bueno, es un tema aún por innovar, pero es verdad que nosotros hemos pasado por todas las fases. Ahora nos sentimos a gusto en las diferentes prótesis. Es verdad que todas las casas comerciales han estandarizado mucho las prótesis, que antes había de muchos tipos, han estandarizado mucho las prótesis, con lo cual han visto el modelo, que este modelo ya tiene una supervivencia mucho más alta, con lo cual ahora simplemente es ir mejorando y mejorando en este sentido.
Sí, sí. Bueno, no nos queda más que despedirnos de esta jornada. Esta jornada ha sido para nosotros un privilegio, una suerte poder estar aquí reunidos en un sitio con muchísimos expertos de cerca, de un poquito más lejos. Han explicado sus experiencias, nos han generado una curiosidad infinita. Les han generado a todos los que habéis visto todas estas presentaciones una curiosidad y yo creo que es un poco el inicio de, ¿no?
Sí.
Muchas veces.
Sí, sí. Bueno, son jornadas que nos ayudan un poco para abrir la mente, que nos ayudan también para entender, nos ayudan también a conocer personas que hacen cosas diferentes y sobre todo no os quedéis siempre con hacemos lo mismo, sino que intentar hacer cosas diferentes.
Sí, hay que pensar un poco outside the box. Muchísimas gracias por la atención. Les agradecemos invertir este tiempo en poder compartir aquí con nosotros y con los ponentes. Y nos vemos en la próxima.
Muchas gracias a todos.